Dear students, I welcome all of you to this discussion of the dermatology questions which appeared in the NEET PG May 2022 exam. Let's begin with discussing question number 1. A patient presented with irregular pitting of the nails with subungual hyperkeratosis and oil drop sign. Let's look at the keywords here. There is pitting of the nails, subungual hyperkeratosis and oil drop sign. Now, pitting of the nails can be seen in two options which is there in the question. Number 1, it can be seen in psoriasis. It can be seen in alopecia areata as well. Now, please remember students, in alopecia areata, we get regular pitting. You get regular, fine, superficial pitting. Subungual hyperkeratosis. This particular feature can be seen in two conditions. Number 1, it can be seen in psoriasis. It can be seen in onychomycosis. So one point which is in favor of onychomycosis is subungual hyperkeratosis is present here. However, very important is in onychomycosis, pitting is absent. Pits are absent. Now, when we talk about lichen planus, what we need to remember, the most common nail change of lichen planus is thinning of the nail. Most common is thinning of the nail plate. And if they ask this question, which is the most characteristic nail change, if the question is most characteristic nail change of lichen planus, the answer is pterygium of the nail. The answer is pterygium of the nail. So with this, we are left with only one option, which is psoriasis as the correct answer. Now let us look at the nail changes of psoriasis. Number 1 is pitting. Number 2 is subungual hyperkeratosis. Number 3 is distal onycholysis. Number 4 is oil drop sign. Let's begin with pits. Now pits are depressions over the nail plate. They are depressions over the nail plate. The importance of pitting in psoriasis is that it is the most common nail change of psoriasis. See these multiple pits here, which are coarse, irregular and deep. You get coarse, irregular and deep pits. So these are the three keywords: coarse, irregular and deep. As you can remember in the question, irregular pitting was mentioned there, and the defect here is in the proximal nail matrix. The defect in pitting is in the proximal portion of the nail matrix. The second important nail change in psoriasis is, this is the nail plate. So what do we see? We see a material below the nail plate which is called subungual hyperkeratosis. Subungual hyperkeratosis. And once this material pushes the nail plate, what will happen? The connection between the bed and the plate is lost, resulting in the separation which is called distal onycholysis. Distal onycholysis. So which is the separation of the nail plate gets separated from the nail bed. The fourth important feature here is oil drop sign, also referred to as salmon patch. Now these patients are going to present with a yellowish red circular discoloration, and very important to remember that oil drop sign is pathognomonic of nail psoriasis. So if we have an MCQ with oil drop sign, it has to be nothing but psoriasis. Question number 2. A 35-year-old came to the dermatology OPD and reports of having intense hair fall for the past 4 months. She had COVID 8 months ago. What could be the most likely diagnosis? Now let's look at the options which are available. Now trichotillomania is more common among women, but here you will have incomplete loss of hair within the patch. So this is a patchy alopecia. This is an example for patchy alopecia. Now if the examiner would want us to mark anagen effluvium, there should be some history suggestive of chemo or radiotherapy. So chemo and radiotherapy, and usually post chemo and radiotherapy 4 weeks later is the hair fall. So after chemo and radio, 3 to 4 weeks later is the hair fall. That is what you need to remember. Female pattern androgenetic alopecia, which is a patterned or genetic cause. Please remember here it is progressive alopecia. It is not sudden, it is progressive and slow. Gradual onset of alopecia is seen in female pattern hair fall. So with this, we come to the answer of telogen effluvium. Now what is telogen effluvium? Telogen effluvium is a type of non-scarring alopecia. It's an example for non-scarring alopecia. Why does it happen? The most important keyword to remember here is severe systemic stress. So please remember, severe significant systemic stress is the initiating factor. And once there is a significant stress, what happens? as a response to the stress, which could be because of malaria, it could be because of typhoid, it could be because of pregnancy, it could be because of major surgery, or it could be because of COVID-19. So any significant systemic stress can trigger telogen effluvium. So after this significant systemic stress, what is going to happen? There is premature. What is going to happen here is premature follicular transition. So suddenly what will happen from the growth phase, from the anagen phase, as a response to stress, the hair is going to the resting phase, which is called as the telogen phase. And we already know in hair cycle, once the hair prematurely grows from anagen to telogen, it is going to remain in the telogen phase for 3 to 4 months. And that is why after 3 to 4 months, there is diffuse hair fall. So diffuse hair fall 3 to 4 months later, after a significant systemic stress, this is in favor of diagnosis of telogen effluvium. Now, what we need to remember here is the mechanism of COVID-19 induced telogen effluvium. Number one, there is production of pro-inflammatory cytokines. A lot of cytokines like interleukin 6 and 4 are produced. As a response to the cytokines, what is going to happen? You're going to have induction of catagen. So what is catagen? Now you have catagen is basically the destruction phase or the involution phase of the hair, where there is catabolism and there is keratinocyte apoptosis. Once there is keratinocyte apoptosis, then you start developing acute telogen effluvium. So this mainly happens as a response to the increased pro-inflammatory cytokines. And how are we going to identify it is intense hair fall 3 to 4 months later after a significant systemic stress. Question number 3. A female with a BMI more than 30. So when a patient says BMI more than 30, we're thinking of obesity. Presented to the dermatology OPD with lesions as shown in the image. So what are we seeing here? We're seeing that a neck has been shown. Okay, and you're seeing hyperpigmented velvety plaques. Hyperpigmented velvety plaques. So hyperpigmented velvety plaques on the neck of an obese lady. What are we thinking of? We have to think of acanthosis nigricans. So our diagnosis now becomes acanthosis nigricans. And now the question is asking, which of the following options do you think are associated with it? A. Hypothyroidism. B. Metabolic syndrome. C. Addison's disease. D. Hypoparathyroidism. The correct answer in relation to obesity has to be metabolic syndrome. So the correct answer for this question is metabolic syndrome, option number B. Now, what are the different causes of acanthosis nigricans? Number 1 is obesity, wherein we spoke about metabolic syndrome. Number 2, we have drugs. Drugs like protease inhibitors and nicotinic acid. Then in terms of endocrine cause, we have to remember polycystic ovarian syndrome. We can also remember Hair-An syndrome. What is the full form of Hair-An syndrome? Hair-An syndrome stands for hyperandrogenism, insulin resistance, acanthosis nigricans. Hyperandrogenism, insulin resistance, acanthosis nigricans. In terms of malignancy, we have to remember GI adenocarcinoma. Now, what is the mechanism? Why is it that in obesity a patient develops acanthosis nigricans? That happens because in obesity there is increased circulating insulin, and once there is circulating insulin is more, what is going to happen? There is going to be increased insulin-like growth factor. So we have a factor called as insulin-like growth factor which gets activated. Once there is activation of insulin-like growth factor, what is going to happen? It is going to stimulate two important things. Number 1, keratinocytes, and number 2, dermal fibroblasts. So because of the keratinocyte stimulation, dermal fibroblast stimulation, you're going to have acanthosis nigricans. Question number 4. A farmer presents with cauliflower-like growth or mass over the foot. Biopsy reveals copper penny bodies. What is the most likely diagnosis? So you have a farmer here in the question. So when you say farmer, they are more prone to develop trauma. There is the cauliflower-like growth over the foot. So farmer plus cauliflower mass. There's only one diagnosis here. Cauliflower mass over the foot. The diagnosis has to be Chromoblastomycosis. So this should be the diagnosis. Biopsy shows copper penny bodies. Yes. Brown colored, round, thick walled bodies. What is your diagnosis? It's Chromoblastomycosis. Mycitoma is not the answer. Why? Because in mycetoma, there will be a farmer who is going to present with a foot lesion, foot is involved, correct, but you will not have cauliflower. Here you're going to have tumefaction, which is swelling, sinus formation, which is number 2, and granules, which is number 3. So we have tumefaction, sinus formation, and discharging granules. Sporotrichosis is a different type of a clinical presentation. In sporotrichosis, what is going to happen? You're going to have nodular ulcerative lesions. Here you have a linear pattern along the extremities. Linear pattern along the extremities because it targets the lymphatics. So chromoblastomycosis, the word chromo means color. That means chromoblastomycosis is produced by pigmented fungi. Pigmented fungi in microbiology is also referred to as dematiaceous fungi. Two important examples to remember here are Fonsecaia pedrosoi and Fialophora verrucosum. And when the patient is going to present to you, first you remember the other name for chromoblastomycosis is verrucous dermatitis. What is the meaning of the word verrucous? Verrucous means anything in dermatology which has a rough or uneven surface. Rough or uneven surface. And in terms of history, what you need to remember, there is a farmer with history of vegetative trauma. Yes, farmer with history of vegetative trauma. What you need to remember here is the patient is going to present with a verrucous plaque with black dots on the surface. So this is a verrucous plaque, rough plaque with black dots on the surface. Another presentation here, you can see one of my patients who had this verrucous plaque on the foot. Second important presentation is cauliflower-like lesions. So you can see these cauliflower-like lesions here. So if you have these cauliflower-like lesions on the foot in a farmer, think of chromoblastomycosis. And on investigations, what are you looking for? You're looking for round, brown, thick-walled bodies. Round, brown, thick-walled bodies. So you can see this thick-walled bodies. So this is called chromoblastomycosis, and these bodies are called copper penny bodies, also known as medlar bodies, also referred to as sclerotic bodies. Next, what is the treatment for chromoblastomycosis? It's itraconazole. Question number 5. A 45-year-old farmer presents with swelling of the foot. So we have a farmer in the question again with swelling of the foot. Presenting with sinus formation. Which of the following is true regarding this condition? So as I mentioned to you in the previous question, when this farmer, swelling, sinuses, think about mycetoma. Now option number B, hematogenous spread, is incorrect. Splendor-Hopley phenomenon can be seen in sporotrichosis. So this option is also incorrect. Involves only superficial tissue is also incorrect because it can involve the subcutaneous tissue. That is why option number D is also incorrect. So that is why the correct answer is going to be caused by both bacteria as well as fungi. That's why we have mycetoma divided into two. If it is produced by bacteria, we call it as actinomycetoma. If it is produced by fungi, we call it as eumycetoma. So this is the correct statement and this becomes the answer. So mycetoma, as I told you, is divided into actinomycetoma, which is bacterial, eumycetoma, which is fungal. So this is a broad classification. When we look at the triad of mycetoma, we need to remember number 1 is swelling, that is tumefaction. Number 2 is sinus formation. Number 3 is discharging granules. And if they ask you what are these granules, always answer it as colonies of the microbe. Colonies of the microbe. So here eumycetoma will have dark black color granules. Actinomycetoma will have pale cream white color granules. And now you can see some images of mycetoma. We are able to appreciate the tumefaction and the nodular swellings over here. You can also see these sinuses which have healed with scars and they have deformed the foot. So this is a very characteristic of mycetoma. If you look at the treatment of mycetoma, we divide it into whether it's actinomycetoma or eumycetoma. Actinomycetoma, we have to go for Welch regimen, which is made up of 2 drugs. Amikacin, which is a aminoglycoside, plus cotrimoxazole. And for eumycetoma, we treat with antifungals. Question number 6. A patient is diagnosed to have anogenital warts. Okay, anogenital warts. is condyloma acuminata. Histopathology reveals squamous cell atypia. That means it is showing some transformation towards malignant changes. Which strain of HPV has got high risk for malignancy? So we need to remember that in anogenital warts, usually anogenital warts are produced by HPV 6 and 11. But please remember students, HPV 6 and 11 are low risk HPVs. They are low risk HPVs. The question is asking high risk for malignancy. So HPV 11 cannot be the answer. What about HPV 2? HPV 2 is going to produce verruca vulgaris. It produces verruca vulgaris. What about HPV 5? Now HPV 5 is implicated in a disorder which is called epidermodysplasia verruciformis. So the correct answer here is HPV number 18. Now HPV number 18 in 10% of the individuals can trigger anogenital warts. Generally anogenital warts is maximally 90% of the times is low risk HPVs. HPV 16 and 18 can be implicated in anogenital warts in 10% of the patients. So here we can see patient of anogenital warts presenting with asymptomatic, pointed, pink papules and plaques. So please remember students that the word pointed means acuminate. That's why this condition is called as condyloma acuminata. Condyloma acuminata is the other name for anogenital warts. Now if you look at the genitals once again, you can see these cauliflower-like lesions here. Cauliflower-like lesions. So if you get these cauliflower-like lesions on the genital mucosa, think about this particular condition. And then when you look at the cell here, you can see that there is a squamous epithelial cell, there is a hyperchromatic nucleus and a perinuclear halo. So if this kind of a cell is mentioned in the exam, squamous epithelial cell, hyperchromatic nucleus, perinuclear halo, think about a coilocyte. So this characteristic cell of HPV is called as a coilocyte. Anesthetic patch over the areas as shown in the image. So you can see that the question is saying this is talking about an anesthetic patch which is seen over the face. This is the anesthetic patch which is seen over the face. The question is asking which of the following nerve is most commonly involved in this condition. Now let us try to estimate as to what is this question asking about. So you can see a skin lesion. We're talking about anesthesia, and we know when you're talking about an anesthetic skin lesion, to think about leprosy, that is Hansen's disease. So we can see that there is a lesion on the face and the lesion is slightly erythematous. So we know that leprosy is a chronic disease, and generally when leprosy is a chronic disease, anything acute which happens in leprosy, that is called as type 1 lepra reaction. It is called as type 1 lepra reaction. So let us keep in mind that there is an anesthetic patch which is slightly looking red in the picture, and then it is on the face. The question is asking which of the following is the most commonly involved nerve in this condition. So let us cross out two options here. Abducent is not the answer. Optic nerve cannot be the answer, because there are two important nerves which are there over the face. Number one, we have the trigeminal nerve which is sensory, and facial nerve which is motor. So the cranial nerves in Hansen's we have to remember are two. The fifth cranial nerve which is predominantly sensory, the seventh cranial nerve which is motor. If there is involvement of the trigeminal nerve, which is sensory, what is going to happen? It is going to result in decreased corneal sensation. This is point number one. Now, when facial nerve, the seventh cranial nerve is involved, what is going to happen? It is responsible for innervating the orbicularis oculi. So, there is paralysis of the orbicularis oculi. When there is paralysis of the orbicularis oculi, which is responsible to close the eye, what is going to happen if it doesn't work? The eye will remain open. You're going to have lag ophthalmos. And when you're having the combination of these two features, decreased corneal sensation and lag ophthalmos, what is going to happen? The eye is open plus the cornea is anesthetic. What is going to happen here? Automatically, it predisposes the patient to develop exposure keratitis, corneal ulceration, corneal opacity, and maybe blindness in the future. Now, what we need to remember is both are commonly involved in the leprosy spectrum, but please remember facial nerve is more commonly involved. Now, why facial nerve is more commonly involved? This is because of the zygomatic branch of the facial nerve. So, this is the explanation which is mentioned in the book. Number 1, the zygomatic branch is motor supply to the orbicularis oculi, the lower portion. So, this is point number 1. Point number 2 is that the course of the zygomatic branch of the facial nerve, it becomes superficial over the zygoma. So, when it becomes superficial over the zygoma, we already know in leprosy is a disorder of the superficial nerves. It involves the superficial nerves because the temperature is cooler. When there is a cooler temperature, it easily gets involved by M. leprae. And when there is a patch on the face, it can easily go into reaction, and when it goes into reaction, the nerves get involved. So this is a point in favor of the zygomatic branch. And the last important point here is it is easily involved, as I told you, when the overlying skin lesion goes into reaction. Reaction means existing lesion becomes red. When this existing lesion, when there is a zygomatic nerve gets red, the nerve which is overlying it gets involved. That is why zygomatic branch of the facial nerve is the most important nerve which is involved there, and that's why the correct answer to this question is the most common cranial nerve which is involved in Hansen's disease is facial nerve. Let us look at some integrated questions with other subjects. A 7-year-old child presents with palpable purpura. When you look at the word palpable purpura, you must think of small vessel vasculitis. When there is a small vessel vasculitis over the lower extremities and buttocks, you see that there is arthralgia, joint involvement. There is also abdominal pain, that is GIT is getting involved. What are we talking about? We're talking about a palpable purpura distributed over the lower extremities and buttocks with associated joint and abdominal symptoms. We're thinking about IgA vasculitis, which is also called as Henoch-Schönlein purpura. And the treatment for Henoch-Schönlein purpura has to be glucocorticoids. Next question, a female patient presents with complaints of thick, curdy white vaginal discharge. So when you say thick, curdy white vaginal discharge, think about candidiasis. On microscopy, budding yeast cells are there with pseudohyphae. That also goes in favor of candidiasis. Which medium is used to differentiate the species of the causative organism? Now, please remember, many students in the exam straight away marked Seborrhoeic dextrosagar. Now, please remember, Seborrhoeic dextrosagar cannot differentiate species. The correct answer here is chrome. Chrome means color. That means based on different colors for different species, chrome agar can distinguish the species of Candida. That's why the correct answer to this question is chrome agar. Next question. A military soldier is presenting with rashes all over the body, sparing the palms and soles. When you're talking about a rash which involves the entire body, which spares the palms and soles, which important condition we should think of? We have to think of epidemic typhus. Now, what else is written in the question? It says, on examination, there is fever and lice are noted. So, lice are noted on the body has to be body louse. So, this also is in sync because body louse can transmit epidemic typhus. Which are the other disorders which can be transmitted by body louse? It can transmit trench fever, relapsing fever, epidemic typhus, and pediculosis corporis. So, 4 important disorders which are transmitted by body louse are number 1, trench fever, relapsing fever, epidemic typhus, and pediculosis corporis. So, we have understood that the question is talking about epidemic typhus. That's why the correct answer for this has to be Rickettsia prowazekii. A wrestler presented with an itchy, scaly lesion over the axilla. On taking scrapings and further investigations, red pigment producing pencil-shaped macroconidia is noted. So, when you have pencil-shaped macroconidia, which species should come to your mind? Trichophyton should come to your mind. So, trichophyton, which is a type of dermatophyte, it's a type of dermatophyte where you get pencil-shaped macroconidia. But obviously, this option is not helping us because all the options have trichophyton. Now, one more clue which is going to help us is red pigment producing. So, what is the other name for red? It is rubrum. That is why by the simple logic, we can come to the answer as Trichophyton rubrum. With this, we conclude this particular session on recall questions.